crime and mental disorders. So let's start with a few definitions. When we talk about mental illness, we're talking about a disorder or disease of the mind that interferes substantially with a person's ability to cope with life on a daily basis. Now, many people have some type of mental health diagnosis. I think it's 1 in 5 people have an anxiety diagnosis in the U.S. And many of them, these are minor mental illnesses or minor mental health issues. Severe mental illness, however, is a different issue, and it's going to be abbreviated as SMI. Mental disorders may not imply that a person is sick, doesn't mean they're to be pitied, doesn't mean they're less responsible for their actions. And then when we talk about an intellectual disability, we're talking about a cognitive deficiency that cannot be cured. Now, the DSM is the Diagnostic and Statistical Manual, and it's published by the APA, the American Psychiatric Association. And we're currently on, I think, DSM-5. It gets updated every so often. And it's a guidebook for mental health professionals to define and diagnose specific mental disorders. Okay, why does this become important? It's mostly for things like, well, first of all, it is going to help your mental health professional figure out a treatment plan for you. But it's also so that you have a diagnosis that gives you access to services and things along those lines. So the mental disorders that are most likely to be associated with criminal behavior are schizophrenic, things on the schizophrenia spectrum, psychotic disorders, bipolar disorder, major depression, and antisocial personality disorder. So let's look at these a little bit. So schizophrenia, right, and various, subsets of schizophrenia, right, and other psychotic disorders are disturbances in cognition, so like how your brain is thinking and functioning, your emotional responses, and behavior. It can include things like delusions, hallucinations, disorganized thinking, grossly disorganized and abnormal motor behavior. And when we say delusions, we mean false beliefs about the world. Okay, there is a girl on TikTok right now who has schizophrenia, and she's been talking extensively about what her experience was like, how she got diagnosed as schizophrenic, and she was having a lot of delusions around a chip being implanted in her brain. Now, this often begins early in life and can lead to a lot of impairments socially, economically, can make it difficult to work. They often will experience breakdowns in thought patterns and emotions and perceptions. Now, this isn't to say that crime is due to these people, right? Small percentage of people with mental illness are committing crimes because of their mental illness, okay? But the level of violence can be higher. And imagine if you are having a psychotic break, if you've had a break from reality, right? You're experiencing delusions, hallucinations, you're not currently experiencing reality. You can see how this could become pretty quickly connected to violent behavior. Okay? And excessive violence was most common amongst those who had hallucinations and delusions. Now, a delusional disorder is the presence of one or more non-bizarre delusions that persist for at least a month. Okay? So, do you believe your neighbor's spying on you and trying to poison your dog? I told you about that young woman that's on TikTok, and she's been talking about how she thought there was a chip implanted in her brain. Now, bipolar disorder is a mood disorder, and it consists of manic phases and depressive phases. And it used to be called manic depression before. And a manic phase is a lot of high energy, distractibility, euphoria. And the depressive side is diminished interest or pleasure in all activities, and it's pretty severe depression when it happens. So this is kind of like two polar extremes, bipolar, right? This can result in reckless behavior during a manic phase that leads to criminal activity. It's not usually implicated in violent crime, but it could be a factor in reckless behavior that then leads to criminal activity. Folks with bipolar have 15 times the lifetime risk of suicide compared to the general population. Now, major depressive disorder, right, is an extremely depressed state that lasts for at least 2 weeks. This is not when you're super sad or depressed in reaction to something that's happened, mourning a loss of somebody, some trauma, right? This is when it's lasted for at least 2 weeks. If you took statistics or are taking statistics now, you might recall that one of the data sets looks at, asks a question that's along these lines, right? Have you been persistently sad? I don't remember the exact wording, but it's for 2 weeks. Okay. So this is a slowing down of mental and physical activity, feeling of gloom and despair, feelings of worthlessness, and perhaps suicidal thoughts. Now, it is strongly associated with delinquency in teenage girls, right? So during our teen years, we're going through a lot of hormonal changes as well. And depression seems to render teens indifferent to their personal safety. And this is how they might end up in a pickle, okay? And the consequences of their actions. And depression does play a major role in school shootings, mass violence, workplace violence, and suicide by cop, okay? So if you know anything about the Columbine mass shooting, both of those gentlemen, I don't know why I just called them gentlemen, both of those young men who committed that mass shooting were very, very, very majorly depressed. Now, antisocial personality disorder, right? This is a history of continuous behavior where the rights of other people are violated, okay? You have to be at least 18 to be diagnosed with this. Remember, psychopathy is a subset of this. Psychopathy is not in the DSM, okay? You have to have had a history of some of the symptoms of conduct disorder, which we've talked about, before age 15. And then at least 3 of the following criteria. Failure to conform to social norms or the criminal law, as reflected by frequent performance of acts that are grounds for arrest. Irritability and unusual aggression, as indicated by repeated physical fights or assaults. Consistent irresponsibility. So this is like shoddy work history, failure to honor financial obligations. Impulsivity or a failure to plan ahead. Deceitfulness, as reflected in frequent lying, use of aliases, or conning other people for personal profit or pleasure. Reckless disregard for the safety of themselves or others. And then lack of remorse or guilt for wrongdoings, as indicated by indifference to or rationalization of having hurt, mistreated, or stolen from somebody else. Okay? Now here's how we might see this play out. We might see this with a lot of stealing or fighting or truancy and resisting authority. We're going to see with this that lack of empathy, that callous, unemotional trait. Contemptuous, feeling contempt for people's feelings and rights and suffering of others. Don't care about any of that. You might see some precocious and aggressive sexual behavior, excessive drinking, and illicit drug use. They have a marked impaired capacity to maintain lasting, close, warm, and responsible relationships. They often fail to become independent, self-supporting adults. They're generally restless. They don't tolerate boredom. They believe the world is hostile. They're impulsive. They're not good at thinking ahead, and they show deficits in executive functioning, right? And that thinking ahead is really required for executive functioning. Now, in the general population, this is anywhere from just under 1% to 3% of the general population, and it is found much more often in men than women. It is a very common diagnosis, though, amongst defendants and offenders. It's also kind of like a catch-all category for people with some of these personality traits. Now, in a correction setting, you're going to see this skyrocket. It could be 30 to 50% of the population. Now, mental defects and disorders can be the grounds for an insanity defense if it has prohibited you from understanding right from wrong or being able to conform your behavior to right and wrong expectations of right and wrong behavior. But personality disorders are not allowed for insanity defenses. So this is not an insanity defense. People who have antisocial personality disorder or are diagnosed psychopaths are well aware of what they're doing. Now, another mental health issue here to think about is whether or not someone's competent to stand trial. And now, generally, people are competent to stand trial. This is just kind of a given. But you can refute this and say you're not competent to stand trial. Being competent to stand trial basically means you are mentally aware enough to consult with your lawyer and to aid in your defense and to understand what's happening, okay? Now, if you're deemed not competent to stand trial, it doesn't mean you'll never stand trial. It means you're going to be in a mental health facility until you are competent to stand trial, and then you would stand trial. Now, Competency, right? If you're going to allege that your client or you as the defendant are not competent to stand trial, you're going to have to undergo some forensic assessments. About 80% of these people are found competent to stand trial. So insanity is an inability to understand that what you're doing is wrong or to conform your behavior to the law due to a mental disease or defect, and it negates the the mens rea, guilty mind, criminal intent element of crimes. Competency to stand trial is something different. It's basically what's your state of mind during trial, during pretrial proceedings. Can you work with your attorney? Now, until the 1970s, if you had been found incompetent to stand trial, you could be held indefinitely. Okay, but in 1972, the Supreme Court held in Jackson v. Indiana that indefinite confinement violates the Constitution. So if no progress is made towards restoring someone's competency, they then either need to be committed civilly, which is a different process. You can go into court and you can have someone committed civilly. We commit chronic sex offender civilly. You can be civilly committed for mental illness. You can be civilly committed for alcohol and drug abuse. Or the person has to be released. Now, if the charges are not serious and you're found not competent, our odds are pretty good they're just going to dismiss the charges. How do we restore competency? It's often through medication, right? And how does that medication address whatever your mental health issue is that's impacting your ability to be competent? Now, the Supreme Court has said you can order people to take medication, but if we're talking about property crimes, crimes that are not crimes of violence, we should really be careful about forcing people to take medication. Okay, so how do we assess whether or not somebody is criminally responsible, right? Mental illness is not sufficient to say like, oh, you're not responsible for that, go about your business. We have to, so in order to be considered not guilty by reason of insanity, we're looking at your state of mind at the time you committed the crime. Competency is your state of mind while you're undergoing the criminal proceedings, okay? Now, the law knows that a mental disorder can rob someone of free will and the ability to make appropriate choices. But this is pretty rare. Insanity is used 1% of the time, and it's successful, I think, also 1% of the time it's used. Okay? Now, we don't have nationwide data on this, but that's the general consensus. Sorry, I lied. It works about 22% of the time. Okay? If you have a psychotic disorder, an affective disorder, an intellectual disability, those have higher rates of acquittal, right? So remember, a psychotic disorder, some type of psychosis, is going to be that you had a break from reality. Personality disorder, can't even plead insanity. Okay? Sex offenders are more likely to be indicted, regardless of the insanity defense. And as I mentioned, these verdicts are difficult to obtain by a jury. So most of the successful insanity cases were not at a jury trial, they were at a bench trial, which is where the judge is both the trier of law and the trier of fact. Cases that are successful tend to be offenders who are older, women, better educated, single, and had a history of prior hospitalizations and were extremely disturbed. So usually you're going to be able to point to, look, this has been a problem for a long time. Now, the M'Naughton rule is one of the early rules for insanity, okay? And it comes about in 1843. And it's basically, at the time of your crime, the offender was laboring under such a defect of reason from disease of the mind as to not know the nature and quality of the act, or if he did know the nature and quality of the act, not know what he was doing was wrong, okay? So this is either a right-wrong test, right? Are you aware of what's right and what's wrong in the moral sense, or an irresistible impulse test? So you did know what you did was wrong, but your mental disease or defect made you powerless to conform your behavior to the law. Now the ALI, so there's like 3 or 4 different definitions of insanity. It depends, are you in the federal system? What does your state use, okay? But this one, the American Law Institute rule, says that disease or mental defects substantially and directly influence your mental or emotional processes, impaired your ability to control your behavior. And it does recognize partial responsibility, that you might be less responsible but still responsible. Now, the Durham Rule is created in 1954, and it assumes that you cannot be held responsible if an unlawful action is the product of mental disease or defect. And this is very vague and subjective. Well, how do I know that, it's because of the mental disease or defect? Okay? And I'm trying to look ahead on my slides. I think this is the one we no longer use. Okay? So, some other changes in insanity. Places a burden of proof on the defendant. So, the defendant doesn't have to prove themselves innocent, right? The prosecution has to prove you guilty beyond a reasonable doubt. The defendant, however, if they plead insanity, the burden is on them to show that they were insane. It restricts the role of clinicians, mental health professionals testifying. And then it requires people who are not guilty by reason of insanity to prove they're no longer mentally ill before they can be released from the mental institution. Because if you're not guilty by reason of insanity, you don't go free, you go to a mental health facility. But you don't go to the same mental health facility you or I might go to if we were having a hard time. You're going to go to one that's basically a prison or a jail. Now, the Insanity Defense Reform Act is at the federal level, and this basically abolishes that irresistible impulse test, and it comes from the John Hinckley case, which resulted in John Hinckley tried to kill President Reagan, I think in 1984, and he was found not guilty by reason of insanity. And they pretty much immediately changed how the insanity defense works at the federal level. And Hinckley was released from custody, released from the mental health hospital, sometime in the last 5 to 10 years. So the mental disease or defect has to be severe. And so here's just kind of a breakdown of when each standard was first used and what the law says. Now, some states have this thing called guilty but mentally ill. Now, for me, legally, grammatically, this doesn't make sense. Okay? So, if you're guilty, it means you had the requisite intent, the intent required by the law to commit the crime that you are accused of. Okay? If your mental disease or defect is severe enough that it is negated, right, it has made your act either not voluntary or negated criminal intent, then you have not committed a crime. You've committed the behavior, but it's not considered criminal. Okay? Guilty but mentally ill is in the middle. She's mentally ill. It played a role in this crime, but it doesn't diminish your responsibility, right? It doesn't take any of that away. Okay? And the idea is that it ensures treatment for people with mental illness, but that hasn't really been accomplished, and we could provide that anyway. Now, there's lots of different unique defenses and conditions that might play a role in criminal behavior. So PTSD could play a role in criminal behavior. We first really learned about PTSD post-Vietnam when, soldiers are coming back and we're seeing how war has impacted and affected them. Excuse me. If you know anybody who has served overseas in a war zone, then you might be pretty familiar with PTSD. Okay? And it happens, but PTSD can be in reaction to many different traumatic events. Now, what you're feeling immediately following a traumatic event is not PTSD. That's acute trauma. Okay? PTSD is usually you've had 6 months of these symptoms. Okay? So it's about 1 to 7% of Americans. Symptoms include things like flashbacks, recurrent dreams and nightmares, painful intrusive memories. It generally results in some diminished responsiveness, some psychological numbing, and it usually begins about 3 months after the trauma. Can really mess with people's sleep. They become easily startled. People with PTSD from war often can't handle fireworks, right? They flash back, they're immediately back wherever they were in battle, have difficulty concentrating, and really go to extremes to avoid things that remind them of the event. Prosecutors are generally willing to be more lenient in these cases and often consider these folks to be less culpable. Now, your post-traumatic stress could be in response to, ongoing domestic violence, sexual assault, right? It can be in response to a lot of different trauma. Sometimes people are experiencing dissociation. They feel detached from themselves, their surroundings, and they've lost some contact with reality. Now, we all do this to a small degree. If you've driven home and all of a sudden you're home and you're like, I don't really remember the drive here, right? You've dissociated a little bit, okay? Or you're like daydreaming, your mind kind of wanders, right? But this can be and include extreme amnesia for past events, okay? And it can be pretty severe, right? So it's a disruption of and discontinuity in the normal integration of our consciousness, our memory, our body, right? Our motor control, our behavior. Now, dissociative identity disorder, DID, is actually very rare, and it used to be called multiple personality disorder. And most of what you've probably seen in a movie about this is probably inaccurate, okay? It's the presence of two or more distinct personalities. This often has recurrent episodes of amnesia. If someone has like switched personalities, you might find yourself all of a sudden in a distant location, not know how you got there, and have like lost some time. And it's generally triggered by stress, and it's very rare. Now, dissociative amnesia is complete or partial memory loss of an event, series of events, or some segment of our experiences due to trauma. Okay? It could be physical trauma, it could be psychological trauma, it could be some kind of neurophysiological disturbance. Retrograde amnesia is a loss of memory for past events. Anterograde amnesia is the inability to form new memories. It could be localized. It could be failure to recall events during a very specific period of time, or it could be generalized and be a complete loss of memory. I had a student once at another school who had no memory of anything before she was 14 years old. Now, if this is related to physiology, your physical being, courts are a little more sympathetic. But it can be pretty difficult to measure if someone is malingering, which is faking it. Now, in terms of mental disorder and violence, as a group, people who are mentally ill are no more likely to commit crimes than those who are not. It is not a direct cause of crime. People aren't like, ooh, I'm anxious, and then they break the law because they're anxious, okay? So, things we should do and movements we have seen taken in the criminal justice system is towards when police are called for some type of disturbance and it turns out it's tied to someone's mental illness, is how do we get them into the right system, okay? So some police departments have jail diversion clinicians. My cousin's husband is a jail diversion clinician. A friend of mine's a jail diversion clinician. Some police departments have social workers. Some have several officers who've been CIT trained, which is crisis intervention training. And it's basically more extensive diversion training, de-escalation training, the ability to recognize when something is related to mental illness. And it generally also involves agreement with other area providers that are mental health folks so that we can channel people into the right system. Okay. Now, mental disorders are 3 times higher in the criminal justice population than in the general population. Now, those with schizophrenia are at increased risk of violent offending and have a higher risk to commit murder. Men who have both schizophrenia and a substance abuse problem are at an increased risk of violent offending. Now, the MacArthur Research Network has developed an iterative classification tree, which helps identify low, average, and high-risk individuals. Okay, and they developed this from inpatients in psych facilities that were in acute care facilities. No single risk factor is a significant predictor. It's like ACEs. It's the accumulation of those risk factors. And here's what some of those are. Past mental disorder alone is not a good predictor of violence. By the way, the best predictor we have of violence is past violence. Same thing for crime. Best predictor of future crime is past crime. Kind of seems like, duh, thank you. The mental disorder most closely associated with violent serious offending is schizophrenia. Those who are schizophrenic and commit violent crimes is a very heterogeneous group. They're very different, right? So there's not like, oh, this is what it looks like. Men who develop schizophrenia and exhibit antisocial behavior at an early age often will then have persistent, versatile patterns of criminal offending. Remember, we talked before about when people start engaging in delinquency, right? And that the people who continue to be persistent offenders start earlier and have individual risk factors. Hey, look at that. This slide is the exact same 5 points twice. Now, amongst inmates with mental disorders, the percentage of inmates in the nation's jails and prison is increasing, okay? About half of inmates have a mental health problem. If you have Professor Boomhauer for a CJ class, he could tell you a lot about this because, as you probably know, he used to run Norfolk County House of Corrections. Why is it that we see so much of this? Well, first of all, like, this is a risk factor for offending behavior, but also, like, who do we call, right, when we see weird, concerning things in the street? Now, that might be, you know, a bear. You saw a bear in your town, you call 911, right? Whenever we see things that we don't know what to deal with, people call 911. Why? It's open 24/7. Okay? Now, the most common problem in inmates is major depression. Duh, right? Jail and prison, not a good time. Even in the best facilities, the safest facilities, that's going to hurt your mental health. So here we can kind of see a breakdown based on a couple different things, right? Across the board, all inmates, jail, state, federal, then by gender, and then by race, right? And we can see that these are all pretty high percentages. Now, a couple things to note, and we cover these in much more detail in forensic psychology if you decide to take that, okay? If you are a mental health professional and you're working with a client who you believe is a danger to someone else, has said something that leads you to believe they're a danger to someone else, an identifiable person, not your client's identifiable, an identifiable victim, you have a duty to warn and a duty to protect, and that is called a Tarasoff warning. Okay, you have a duty to notify that person, to notify law enforcement. Kind of depends on the situation. And this comes out of a case, Tarasoff versus Regents of, I don't remember which college it was, where the police department and a mental health professional on campus both knew this man was a danger, and he did eventually kill a woman that he had been like having weird, violent fantasies about. Now, risk assessment, how do we know how much of a risk someone is? Well, this is complicated, right? We can do threat assessments, we can do a lot of tools, but some of our best predictors of future behavior is past behavior. Okay, great. Let's throw them in an algorithm and see what shakes out. The problem with that is that a lot of the things that are good predictors are what's called static factors. They're things that don't change, as opposed to dynamic factors, things that do change. So static factors about me would be that I'm a woman, that I'm a white lady. If I had a criminal record, which I do not, that doesn't change, right? And those are the things that are like, criminal record is a better predictor, okay? So that's part of our problem with risk assessment. We're also just not great at predicting human behavior. I mean, think about yourself. There's days where you might react like totally calmly to something that normally would kind of like send you off your rocker, and the people around you might be like, whoa, you're taking this very well. We often don't know why. Sometimes we're just in a better mood and we can let things roll off our back. Sometimes we're not. So there's different approaches to this. One is an actuarial approach, right? And that can be based on research, piles of risk factors and needs factors. You can do something that's more clinical judgment, right? I mean, ideally you're using a combination of both. You're not just like, Dr. Spencer sat down with me and she doesn't get good vibes from this. It's a little concerning to me, right? That would be a structured professional judgment. Okay, first generation measures, right? So this is like, how have we gotten better at measuring this? Are based on unstructured clinical judgments. Second generation, that's primarily those static variables, things you can't change about yourself, like a history of abuse. Third generation variables are criminogenic needs. And fourth generation variables are looking at treatment and rehab processes. Now, using risk factors, we're about 17% better at predicting what will happen with someone than just clinical judgment alone, but we're still not good at it. And here's kind of a breakdown of that.